I would like to invite our next speaker, Dr. Richard Allen. He is Professor Oculoplasty at Baylor College of Medicine, Texas Children's Hospital, and he has edited and narrated over 300 oculoplastic surgery videos. And I think every oculoplastic surgeon who is going to operate for the first or second time sees his videos before going to the OR. He has several publications, and today he'll be discussing about the PD-1 inhibitors' role in eyelid and orbital malignancies.
All right. Thank you so much for inviting me to participate. Really, really appreciate it. Look forward to hopefully seeing some of you next week in Malaysia. Let me see if I can share my slide and hopefully you all can see it. Okay, great. So I just want to talk a little bit about PD-1 inhibitors and some of the lessons that I've had lately or learned lately from them. I have no financial disclosures. As you know, targeted agents are really sort of the future of oncology and rheumatology treatments. The idea more than anything else is to target specific molecules for tumor growth to get more precision with fewer side effects. This can be applied to orbital, eyelid, lacrimal disease, oncologic, as well as inflammatory conditions. When we think about traditional treatment of orbital malignancy, this has usually been surgical excision, at least having a component of that in our treatment. However, this can be disfiguring and sometimes it can be incomplete. And if it's incomplete, it's really not an oncologic surgery. We can always apply radiation. However, this can also affect adjacent structures, especially the eye. And then we can always use traditional chemotherapy, but the problem with traditional chemotherapy is that it is relatively nonspecific and affects the normal populations of cells. So any cells with a high mitotic rate, and therefore you're going to get side effects from that. When we think about molecularly targeted agents, just generally, we usually split this into either monoclonal antibodies or small molecule inhibitors. You can always tell from the name which is which, because if it's a monoclonal antibody, it's going to end in MAB. If the small molecule inhibitor, it's going to end in IV. When we think about monoclonal antibodies, really the way these work is that they target specific antigens. This is always intravenous or subcutaneous therapy. It can sometimes be intralesional, usually going to target transmembrane receptors, extracellular growth factors. When we think about how this works, basically it's going to be an antibody to a specific marker on the cell. So either block a receptor and disable the signaling pathway, or potentially we can use it as an immune response to the antibody antigen complex, which results in death of the cell. However, lately, the big thing in oncology is to use these to block a checkpoint in the immune system, and that's what we're going to talk a little bit about today. Small molecules are usually oral therapy. They're small molecules, so they penetrate the cell membrane, and usually they're going to interfere with a metabolic or enzymatic step within the target cell. So it's sort of easy to think about those two. Monoclonal antibodies, you're going to give them intravenously or subcutaneously. They're not going to get inside the cell, whereas with small molecule inhibitors, they're small molecules. They can be given orally and they're going to be able to get into the cell. However, we're going to talk about a little about immunotherapy this evening, and these two guys actually won the Nobel Prize for this. Checkpoint inhibitors really take advantage of the host's immune system to fight abnormal cells. And I think the easiest way for us to think about this is, when we think about our worst cancer patients, they're usually immunosuppressed. When I think about some of my worst cancer patients, these are usually patients that are immunosuppressed, especially patients with squamous cell carcinomas of the skin, cutaneous squamous cell carcinomas. We need a healthy immune system to prevent development of neoplasms. So when I have that patient that has a salad organ transplant or a history of CLL, these usually develop the worst cutaneous non-melanoma skin cancers. However, some of these tumors overexpress immune checkpoint molecules. And so there's really two pathways that are now targeted with regards to immunotherapy: the cytotoxic T lymphocyte-associated antigen 4 pathway, which is CTLA4, and then you have programmed cell death, so PD-1, PD-L1, basically. So the way anti-CTLA4 antibodies work is really CTLA4 is expressed on cytotoxic T cells and regulates and inhibits T cell activation. So by blocking this, this is going to enhance T cell response. So basically, you are just trying to jazz up the immune system. And this can have some untoward results also, because essentially you're placing this patient's immune system in overdrive. And so they can also have some autoimmune issues, and we'll talk a little bit about that. So you're sort of giving them an autoimmune disease when you sort of think about it. PD-1 inhibitors, basically limits the activities of PD-1 limits the activity of T cells. So by binding this, it basically allows these T cells to reactivate. And so you can block either PD-1 or PD-L1 or potentially PD-L2. And this has really been used a lot in metastatic melanoma and lung cancer. So how are we using these in eyelid and orbital oncology? Well, cutaneous squamous cell carcinoma has really, the treatment of cutaneous squamous cell carcinoma for me has really changed with the use of PD-1 inhibitors. Conjunctival squamous cell carcinoma, I don't take a lot of care of a lot of squamous cell carcinoma, but this has also been reported to be successful. And, sebaceous carcinoma, some varied results, but what we do know is that PD-1 is expressed in some of the sebaceous carcinomas. There have been anecdotal reports of, some tremendous responses to PD-1 inhibitors, but right now it's not really used a lot. Basal cell carcinoma, some reports with regards to its use. There was some initial excitement about the potential of using these with lacrimal gland carcinoma. However, it really hasn't panned out. And then Merkel cell carcinoma does, some of these do express PD-1, so it has been used in Merkel cell carcinoma. However, this is just from JAMA Dermatology 2017, basically showing a patient with squamous cell carcinoma then being treated with pembrolizumab, PD-1 inhibitor, and this is just purely with treatment with immunotherapy, no surgery or anything like that. Pretty amazing. What I see, the biggest effect it's had for me is in the treatment of patients with perineural spread of their squamous cell carcinoma. So here's a patient who has a history of a lower lid squamous cell carcinoma, now with perineural extension along their infraorbital nerve. In the old days, you didn't have very good treatment. Maybe you would consider exoneration, but in general, we believe that exoneration probably doesn't really help all that much. It might control the local disease, but then you're going to give them radiation afterwards, and potentially they're going to have intracranial extension. Now, here's a patient that I saw just about a year ago who came in. He had actually lost his eye on the right eye due to perineural extension of his squamous cell carcinoma. His eye was eviscerated due to the fact that he had a neurotrophic cornea and basically had perfed his eye due to that. He has extension along the supraorbital nerve, and here he is after treatment with a PD-1 inhibitor. And here's his axial view. Again, you can see he's lost his eye. He has extensive perineural invasion, even into his cavernous sinus. Here he is just after treatment with the PD-1 inhibitor, and essentially no evidence of disease. So really pretty amazing results when I've seen some of these patients. Here's another patient that I saw with perineural extension along her infraorbital nerve. Here she is just, purely just after treatment with immunotherapy, no evidence of disease. So pretty amazing results, something that I never thought I would have seen, probably 15 years ago. These were very difficult patients to treat because you basically had a surgical approach to them followed by radiation, and usually that surgical approach was going to involve exoneration. Here's a patient with a Merkel cell. So here's one of my patients came with a Merkel cell, pretty extensive Merkel cell here, sent to the, I always get the medical oncologists involved as well as my head and neck surgeons involved because these patients will need a sentinel lymph node biopsy. And here, and the medical oncologist said, let's try PD-1 inhibitor. Okay. Now there's this question about progression versus pseudoprogression. So part of the problem is that when you put these patients on immunotherapy, they may have an inflammatory response to the tumor. which may make it look larger. And the question is this true progression or is this pseudo progression? Pseudo progression meaning that it's just an inflammatory response that we're seeing rather than progression. Well, this is what he looked like, about a month later, and this is true progression. This was not pseudo progression. So this is one of my Merkel cell patients who did not respond to PD-1 inhibition, but early on it was sort of it was sort of confusing because early on we saw some growth to the tumor and we were trying to figure out whether this was pseudo progression or whether this was true progression. But in the end, this was true progression. Unfortunately, this patient actually died from his disease. Now, since we are sort of placing your immune system in overdrive, you can get a lot of adverse events or side effects from checkpoint inhibitors. Again, the way I sort of think about it is that you're just giving these patients an autoimmune disease, and you're hoping that that autoimmune disease just attacks the tumor, but it can also cause some other problems with regards to the patients. And a lot of patients will have to stop these medications due to the adverse events. So what do we see with regards to ocular side effects? Orbital inflammatory disease, we see uveitis, scleritis. There's reports of induction of thyroid orbitopathy, even with the development of hyperthyroidism. I've seen a lot of lacrimal gland inflammation associated with immunotherapy, myasthenia gravis, scoliosis, even some in ophthalmos. So I'm just going to show you a patient here, 69-year-old who has a history of metastatic prostate adenocarcinoma, and he notes acute painless ptosis on the left greater than the right. Well, noted on awakening about a week ago, no other neurological deficit, no swallowing issues, no headache, scalp tenderness, jaw claudication. He has a history of metastatic castration-resistant prostate cancer. And basically, he has been placed on not just CTLA-4 inhibition, but also PD-1. So he's on basically double dose of immunotherapy targeting both pathways. And so the concern here was myasthenia or myositis or even metastasis. We imaged him, everything looked good, and it was determined that he actually had myasthenia from his immunotherapy. Here he is 8 weeks later, and here he is 8 months after presentation. But he had to stop his immunotherapy due to this, and he actually succumbed to his disease about a year later. And so even though these medications can be great, not everybody can tolerate them. Just going to show you one last case, and this is one of my patients who came in, it was about a year and a half ago, and she was referred in for recurrent squamous cell carcinoma of the left orbit and left lower lid. She had a history of a cutaneous squamous cell carcinoma that was removed, and unfortunately, she now has a recurrence. And pretty big squamous cell. You can see her motility here, and she obviously has some orbital extension here. And so, basically I discussed with her what to do. We're sort of leaning towards exoneration for her. But I sent her to the medical oncologist, and medical oncologist worked her up. And when they worked her up, they actually found that she had a lung mass. And it ended up that she had a primary carcinoma of the lung as well. She was a heavy smoker. And so she had two primaries, this squamous cell on her left lower lid, as well as this lung carcinoma. Medical oncologist said, really the lung carcinoma is more important than what you're seeing on the eyelid. They're going to treat her for that. And so they treated her with traditional chemotherapy, and her squamous cell actually responded to that. And so, it gave us some time. And I said, okay, we have a little time here. She's being treated with traditional. I was going to look up what she was given exactly, and I don't have that down. I apologize for that. But she was treated with traditional chemotherapy for her lung cancer, and her squamous cell on her eyelid and her orbit actually improved. So here it is. And then they actually started treating her with some immunotherapy for her lung cancer as well. And you can see she had a very nice response. So even better, and, doing pretty well. And now I'm starting to think, well, maybe I can resect this, or maybe I can just buy time here and, not exonerate her. And I was hoping for that. And so even on down gaze, you see last time her motility was affected, her motility is improved. However, unfortunately, she experienced some adverse effects from her immunotherapy, and she stopped her immunotherapy. And this was what she looked like 10 weeks after stopping her immunotherapy. So immunotherapy works. And, this is just a ridiculous response. When I saw her come in, I couldn't believe that she didn't call me sooner, but, big time progression after stopping her immunotherapy. And so this ended up being a surgical problem for her. And unfortunately, she was exonerated with a free flap placed. But I think, take advantage of these newer therapies in the care of your patients. I don't think they're going away. I think this really is part of the future of oncologic care. Involve your medical oncologist, and sometimes you have to involve the rheumatologist as well. I think the biggest issue with these is that they're very expensive and probably prevent widespread use, at least in the near term. Thank you again for inviting me to participate this morning. Really, really appreciate it. Hope to see some of you next week, and happy to take any questions if there are any.